All right, welcome back to The Explainer. Today we are diving into a literal masterclass on three of the most life-threatening hematologic emergencies you will ever face: TTP, HUS, and DIC. We're going to break down the pathophysiology and give you the absolute definitive framework to differentiate them flawlessly. Let's just jump right in. Okay, picture this. We're starting with a massive, high-stakes clinical mystery. A 35-year-old patient rolls into the emergency department. They are febrile, they're severely confused, totally disoriented. You look closely at their skin and you see petechiae. You know, those tiny pinpoint hemorrhages? Their labs come back showing profound anemia and acute renal failure. Now, this is the classic, terrifying presentation of TTP: fever, anemia, thrombocytopenia, renal failure, and neurologic symptoms. That Pentad, that is your absolute red flag. But look, to really understand why this patient is crashing so incredibly fast, we can't just memorize the symptoms. We have to look at the source.
So we're going to zoom way in right now. We're transitioning sharply from the macro view of our crashing patient in the ER straight down to the microscopic level of the endothelium. Because the entire pathology of these diseases, it all stems from a microscopic failure of blood flow regulation.
Okay, let's dive into this master regulatory mechanism. I want you to meet ADMTS13. Normally, your endothelial cells secrete von Willebrand factor, or VWF, in these massive, sticky, ultra-large multimers. Honestly, think of them as giant biological nets that are literally designed to catch platelets. Now, if left unchecked, these giant nets would clog up your entire circulatory system. And that is exactly where ADMTS13 comes in. It's a highly specific protease that circulates in your plasma, and it acts exactly like a pair of molecular scissors. It snips these ultra-large multimers down to a safe, manageable size, ensuring your blood just flows smoothly. But what happens when you lose those molecular scissors? Well, in TTP, the patient either has a congenital mutation, or much more commonly, they develop autoantibodies that actually neutralize ADAMTS13. You lose the scissors. And without ADAMTS13, those ultra-large, ultra-sticky VFF nets just unspool right into the flowing blood and act like massive traps. Platelets flowing by get snagged, more platelets pile on, and suddenly you get these massive, unchecked platelet-rich microthrombi forming directly inside the small blood vessels. It plugs up the microcirculation of the brain, the kidneys, the heart. This is exactly why our patient is confused and in renal failure. Their organs are quite literally suffocating from microscopic clots. Now, let's pivot for a second and look at a really closely related cousin to TTP, hemolytic uremic syndrome, or HUS. We're going to change the clinical scenario entirely. Imagine a pediatric patient who shows up to the ER with acute kidney injury and bloody diarrhea, just a few days after eating an undercooked burger at a family barbecue. So here is the absolutely crucial point. The phenotype of HUS looks incredibly similar to TTP. I mean, they both feature massive microscopic clotting. But the trigger? The trigger is entirely different. In typical infection-associated HUS, it's not missing scissors. The patient actually ingested Shiga Toxin secreting E. coli, usually O157H7. This toxin directly attacks and severely damages the endothelial cells, particularly in the kidneys. It's this massive endothelial damage and the subsequent complement activation that trigger the localized formation of those platelet microthrombi. It's an injury-driven clot, and it severely targets renal function. Let's actually visualize this battleground inside the blood vessels. Look over on the right, you can see a physical microthrombus completely blocking the vessel. But on the left, check out those jagged, fragmented red blood cells. See those sharp edges? Those are schistocytes. Basically, as normal red blood cells get pumped through the microcirculation at high velocity, they literally slam into these tight webs of VWF and platelet microthrombi. The physical force just shears the red blood cells apart. We call this microangiopathic hemolytic anemia, or MAHA. And finding these schistocytes on a peripheral blood smear, that is the absolute cornerstone of diagnosing these conditions. Look, just memorizing lab values is pretty much useless. Understanding the mechanics is everything. So let's break down exactly what you are going to see in the lab report and why. Platelets, they're low, but not because the bone marrow isn't making them. It's because they're being heavily consumed and physically trapped in thousands of microthrombi. LDH, or lactate dehydrogenase, wildly elevated. Why? Because it's spilling right out of those thousands of red blood cells being violently sheared apart in the vessels. And haptoglobin, it's heavily depleted because haptoglobin acts as the body's sponge for free hemoglobin. When red cells burst, they release free hemoglobin into the blood, haptoglobin binds it all up and gets cleared out of circulation, dropping its measurable levels down to almost zero. All right, so we've firmly established the catastrophic microangiopathic profile of TTP and HUS.
But here is the ultimate clinical trap. There is another massive systemic clotting disaster out there that also causes low platelets, it also causes schistocytes, and it also causes organ failure. It's called disseminated intravascular coagulation, or DIC. And if you mix these up, your patient dies. It's that serious. So, how do we confidently differentiate them? Putting these profiles side by side builds the ultimate board exam concept. Look at this. Platelets are low in both. Schistocytes are present in both. You literally cannot differentiate them based on the blood smear alone. But look right at the coagulation panel. In TTP and HUS, the PT and APTT are completely normal. Fibrinogen is normal. But over in DIC, the PT and APTT are massively prolonged, and fibrinogen is totally depleted. I am going to hammer this home right now because this is the single most important differentiating heuristic you can possibly have in your clinical toolkit. If a patient is crashing with massive clotting, low platelets, and cystocytes, but their coagulation times, their PT and PTT are totally normal, it is not DIC. You have to immediately suspect TTP or HUS. But to be a truly elite clinician, you can't just know the rule. You must understand the why behind it. Why is the PT/PTT normal in TTP? Well, it all comes down to the actual composition of the thrombus. In TTP and HUS, the primary defect is isolated to VWF and platelets. They form what we call white clots, platelet-rich microthrombi. The secondary hemostasis pathway, the whole protein coagulation cascade with factors 7, 8, 9, 10, thrombin, fibrin, that remains completely untouched and unactivated. Therefore, the PT and PTT stay normal. But DIC? DIC is a massive unregulated activation of tissue factor and the entire coagulation cascade. It actively consumes and depletes all your clotting factors and your fibrinogen to make massive fibrin-rich clots everywhere. Because those factors are all used up, the PT and PTT naturally prolong. Which finally brings us to the ultimate clinical intervention. Before we had modern treatments, the mortality rate for TTP was a staggering 90%. Let that sink in. Today, the immediate, rapid initiation of therapeutic plasma exchange, or PLEX, is completely life-saving. Based on everything we literally just covered about the pathogenesis, ask yourself, mechanically, why does PLEX work so beautifully? It's because PLEX effectively performs two life-saving maneuvers at the exact same time. It removes the patient's plasma, taking those rogue ADAMS13 autoantibodies with it, and it replaces it with fresh donor plasma, which is absolutely packed with fully functional ADAMS13 molecular scissors. You are literally giving them back the tool they need to cut those massive VWF nets and clear the microthrombi. Understanding this beautiful link between cellular pathogenesis and clinical treatment, that is exactly what separates rote memorization from true medical mastery. But here's a final thought to ponder as you head back out to the wards. As we master these plasma exchanges, what happens when a patient's autoantibodies are entirely refractory to PLEX? What new targeted immunotherapies are on the horizon for those non-responders? Keep these frameworks sharp, keep asking those questions, and I'll see you in the next explainer.